Good evening, everyone. Uh, and I'm thankful for the organizers for allowing me to speak up, do justice in such a short time. So what is CTGA? CTGA is a double discordance, as you can see from these pictures. And for best treatment, so what is the best treatment? The best treatment is what suits your patient best. Should be able to treat the ailment and save life, should be without any significant morbidity, should have sustained and long-term benefits, and it should be an evidence-based treatment and should be cost-effective. And that's the most important criteria probably for our country. Now, let us try and fit these criteria to the CTGA. So as I said, it's defined as a double discordance where morphological right ventricle supports the systemic circulation, and it's extremely rare. Condition occurs only in 1 per 33,000 live birth and 0.05% of all congenital heart disease. So in regular practice, most of pediatric cardiologists or many of us are not exposed to the variety of CTGAs that exists. And only 20% of CTGAs have isolated CTGA, where the rest of them have associated lesions, which could be VSD, in 75%, pulmonary stenosis, Epstein anomaly of tricuspid valve, mitral valve abnormalities, and conduction abnormalities. For the purpose of treatment, CTGA is divided into 3 subcategories: CTGA with large VSD, CTGA with intact IVS, and CCTGA with rootable VSD or non-rootable VSDs. So we'll take these 3 categories. Non-rootable VSDs probably should be, I'll keep out of this talk. Each subtype may be associated with tricuspid valve abnormalities or conduction defects. These are just few examples. If you can see the above, this is the regular CCTGA. Here you can see the Epstein's, and this one is with the inlet VSD. And this one is CCTGA intact septum with LVOTO. So 3 subtypes not only are different in their presentations, but they are different in their management and also in different outcomes. And each subtypes can be associated with heterogeneity. So probably we cannot have one glove fits all kind of approach. And the rarity of lesion is such that many sub-centers may not see that it's very common. So we have different type of strategies in different institutions. Hence, there is a big confusion to what to do for each given patient. So let's talk about the controversies. Controversies are basically determined by the surgical and the cardiology team, but mainly by the surgical team's experience. And what may seem simple in one unit will be difficult for another surgeon because of the exposure. So hence, there are controversies for the best treatment. So something which is non-controversial, let me talk about those facts. One is the physiological repair. Physiological repair is when you just correct the abnormality, but you do not do the atrial or the arterial switch. You retain the RV as the systemic ventricle. And the repair was initially propagated by the fact that certain CTGAs were discovered even in the 6th decade of life, enjoying healthy life. But if you question them and you on questioning, the symptoms of CHF actually occurred even decades before they're presenting to the hospital. And most CTGAs develop progressive TR and systemic RV function. And various studies have showed that most CTGAs, if RV left in systemic circulate as systemic ventricle, have a survival rate of just 50% at 20 years. So CTGA classical repair has been given up. So this is non-controversial, and this is reflected similar by the graph. Now CTGA large VSD, again, most of the time the repair is non-controversial. We go through PA band. In some surgeons may want to do it just to control the CHF and allow the child to grow bigger, because senning usually most surgeons do not want to do before 4 or 5 months of age. So if they have done the PA band and the child has grown bigger, then they can do a senning baffle. But doing PA band creates a problem on the pulmonary route, and that becomes a neo-aorta. So neo-AR will be a concern, and also late onset atrial arrhythmias can be a problem. But still, In most centers, CTGA large VSD will be treated by a double switch. So what are the controversial aspects? Controversies are CTGA intact interventricular septum, and there are multiple pathways because some centers may do a medical follow-up till the patient becomes symptomatic. Some centers have proposed elective PA banding so as to plan double switch for every patient with CTGA intact septum with or without associated lesions. Palliative PA banding, say a patient presenting with symptoms. Tricuspid valve repairs or replacement present, especially in the older age groups, and cardiac transplant once the patient has developed ventricular dysfunction. Now, if you look at the PA band, the idea of PA band is that we know that the left ventricle regresses soon after birth. So if you want to do a double switch for any given patient, you have to ensure that the left ventricle is ready to face the systemic loads. So you have to do a double switch is considered like, you know, Ramban or panacea of all treatments. So PA band came into picture that let's prepare this LV just similar as they would do it for the regressed LV in transposition. So PA band is preparatory steps toward double switch operation, especially with the regressed LV. LV pressure, what you achieve is a 50 to 60% at the time of band, and it does cause septal shift. So there is a septal shift hypothesis, and it also controls the progression of TR. So even if the patient doesn't prepare, the patient will still get benefited by reducing the TR and reducing the right ventricular failure. The symptomatic benefits do happen. And there should be no new MR at the time of PA band. And there should be minimal or no LV dysfunction at the time of PA band. So PA band is usually done under TE or echo guidance. And what are the criteria when you say that that patient is ready for double switch? So LVEF should be more than 60%, and indexed LV volume should be like about 40 to 100. That's a huge range, but 40 to 100 ml per meter square. LV mass more than 50 grams per meter square. Some people have advocated about 75. LV mass volume ratio of more than 0.5. LV pressures at least 90% of the RV, but some use about 75. And LV ED less than 10. And there should be no more than mild MR. And if there's more than mild MR, then it should be a correctable lesion such as cleft. But then MR will mask the LV dysfunction, if any. And double switch operation can be done when the LV is considered prepared. What we certainly know about this double switch operation is that, one, as I said, that LV has lost its mass, so it will not work without training. And myocytes do not multiply beyond infancy, or rather early neonatal. So what you get later on is hyperplasia. So which means that whatever muscle mass you're gaining, say a child who comes at 2 years or 3 years of age, and you do a PA band, you're only going to get hypertrophy and not hyperplasia. So that is the reason some patients do not get prepared, because they do not get adequate muscle hypertrophy. And only 62% patients under 12 years get prepared, and beyond 12 or 14 years, most patients do not get prepared. And certain things we do not understand is what is the correct age of PA band. Should we do it children less than 2 years? Should we do it for 5 years at 5 years? Or should we do it for everyone who is under 12? We don't know. Should it be done electively, or should we wait till the TR develops? So in a study by Myers et al., they have said that all those patients who underwent PA band at under 2 years of age, they did not suffer LV dysfunction as compared to older patients. So that was something useful, and their follow-up was probably up to 10 years. So then there is a question of, can we leave this PA band as final palliation? So you don't want to do double switch because you are risking the LV failure in long term. So can we leave this PA band as final palliation? And especially for patients who are presenting late with TR and RV dysfunction. So when you do a double switch, say prepared LV, what happens? LV dysfunction occurs in many patients, irrespective of duration or pre-op LV pressures. and incidence is huge. It's 26 to 30% in 50. So you're 1/3 to 1/4 patients develop LV failure, and then you have no treatment but to send them for a cardiac transplant. And what possible causes of this LV dysfunction? It's probably one of the factors that has been proposed is a late age, so patients presenting later. Aggressive PA band. Suppose a surgeon does a very tight PA band because he feels that, okay, when I've raised this pressure, the patient may not prepare, then I'll have to go in again and do another PA band. So, but that causes subendocardial ischemia and fibrosis. So these patients will actually have depleted myocardial cells. And as I said, it's more of hyperplasia than hyperplasia. And there's an important study which came out, which says that there is inadequate capillary growth. So the there is increase in the myocyte fiber, but the capillaries were lesser when patients underwent PA band. Myocyte diameter was approximately 50% larger as compared to normal patients, and capillaries were 20% less. So which means that whatever you are doing is not physiological. So we are not surprised that these patients will develop LV dysfunction. So prophylactic PA band was proposed by Wu et al. And they said all patients should be banded in infancy. So are we ready for that? Probably many families will never agree. So, but again, from the same group, they have this paper, and that has shown that patients who underwent prophylactic PA band during infancy did not have any LV dysfunction at the end of 5 years, but long-term studies are yet to be seen. And PA band as final palliation, this comes as for patients who had TR-RV dysfunction or presenting as later age. What PA band does, as I've already spoken, that it restores the RV geometry, it reduces TR, there is improvement in function class. And this, again, this is a data which comes from Ma et al. And it has shown that PA band as final palliation had very good survival, and there was no risk of ventricular failure as compared to double switch group. So this is their data where they did the PA band, and they showed that the significance TR reduced after PA band. And they also have shown that when you did a double switch after PA band and they left the patients alone, the PA patient and the follow-up is for 50 months. The post PA band, that is palliated group, has a better survivor as compared to patients who underwent double switch surgery. What happens to the aortic valve? So yes, aortic root dilatation is known to occur. Just as for TGS, aortic root will dilate here because it is actually the pulmonary valve. So almost 70% patients have aortic root dilatation at the end of 15 years, and more so if they had a ventricular septal defect. So in the series by from Boston, 13% children required reoperations of the aortic root during their first 5-year follow-ups. And pulmonic stenosis and LVOT resection at the time of double switch also predisposed to aortic valve, because in presence of pulmonary stenosis, aorta is already dilated, just like tetralogy. So these patients are prone to develop more aortic incompetence. With increased number of follow-up years, there is increase in aortic valve dysfunction and should be anticipated in more and more patients. So coming on to the next group, CTJ VSD PS. Again, the treatment varies between various units. Some units want to do only double switch. Some units want to do Fontan, and some maybe probably want to rationalize. Anyway, the two main strategies are double switch or the biventricular repair, which is called the Restelli-Senning, and the univentricular repair, which is Fontan. So what happens? Why people want to do biventricular repair? Because most surgeons consider Fontan is a poor choice when they can do a biventricular repair. Fontan is left for patients with unfavorable anatomy. And as I said, unfavorable anatomy could be a non-routable VSD. So what is unfavorable? Probably it again depends on the surgical experience. So based on the experience, the surgeons may choose different pathways for same anatomy. So hence, we have no consensus, but As we all know that CTGs have smallish RVs and smallish tricuspid valve as compared to any other cyanotic lesion. So for a Rastelli, it was proposed that RV volume should be at least 120% of the normal values. So for CTGs, there was no criteria, and most of the times we were using the tricuspid valve Z-scores and looking at if the tricuspid valve was all right. We were not looking at the RV volumes, but that was not helpful. It was counterproductive, and a couple of our patients developed LV dysfunction as a result of double switch in these patients, rather Rastelli. So I came across this data which says that if RV volume was greater than 80% and tricuspid valve Z-score was more than -2, then it was suitable for biventricular repair, and otherwise you should look for a Fontan procedure. STS data has showed that Senning Rastelli has the highest mortality rate, about 8.4%. It has decent good long-term survival, but post-operative complications are again highest and were seen in 71.4% patients. Major complications requiring re-explorations were seen in 38.2%. Rhythm disturbances occurs in 15%, and highest re-operation rate, approaching to almost 50% in follow-up. That means 50% patients are going to come for resurgery, and those resurgeries would be in the form of conduit replacements or Senning baffle repairs or residual VSTs. So this is at 20 years, almost 50% patients have required re-explorations or resurgeries, and actual survival was 70% at the end of 20 years. So what happens when you do Fontan? You get a similar survival. You get a similar survival at the end of 20 years. You have 65 to 72% survival, and rather immediate survival in some studies has been 90 to 100%. There was 91.3% freedom from death during the study period, and there was a very, very high degree of freedom from reoperations. So this was event-free survival. If you look at it, so almost 80% event-free survival. So these are the survival probabilities on anatomical, conventional, and single ventricle. So we have ignored already that the conventional repair is bad, but if you look at the anatomical repair and you look at the Fontan, so Fontan does have an immediate survival advantage. So long-term disadvantage of Fontan, which we are worried, are basically hepatoma, cirrhosis, protein-losing enteropathy, and plastic bronchitis. So people have left this Fontan option as for patients who are considered not suitable for biventricular repair, so non-septatable hearts. So remote VSDs, unequal chamber size, straddling valves, and various complex anatomies. But in our country, I think social reasons should be included, and the families who cannot afford recurrent costs should be offered this kind of treatment. Aortic root translocation is now the new trend, which says that it is superior because it doing an aortic root translocation, the RV size which gets compromised during the Rastelli doesn't happen, and it gives a straighter pathway from LV to aorta, and also that the enlargement of LVOT, if required, does not create any troubles, and theoretically it provides advantage that LVOT becomes more physiological and avoids a vertical incision for conduit replacement and reduces number of reoperations. But it's a more complex surgery, it's a time-consuming surgery, and it has a steeper learning curve, and because of rarity of lesion, so we need to have these long-term results we are still awaited. Pacemaker implantation. Almost 38% patients will require pacemaker by end of 40 years, and nitrogenic heart blocks occurs in almost 15 to 16% patients. And highest risk of heart block occurred with double switch as compared to Rastelli, and least with the Fontan. And use of biventricular pacing is recommended because univentricular pacing or a dual chamber pacing was creating havoc with these patients. A lot of these patients with univentricular pacing developed progressive LV dysfunction. So it was Haverberth et al. Who showed that out of 53 patients, 11 patients who received biventricular pacing as the initial pacemaker did not have any ventricular dysfunction. So we still have to think that should all patients who with CCTJ, should they receive a biventricular pacing? And there are still juries not out. But as of now, whatever literature I could read, most of the time what is recommended is a biventricular pacing. So take home message, a double switch surgery should be considered in all patients with large shunts, large post tricuspid shunts. CCTJ with intact septum should receive PA band. I'm sorry, there's a typing error. Receive PA banding if presenting before 2 years of age with intention of doing double switch operation. Those presenting late should receive PA band anyway, because double switch may or may not happen. And yes, patients should be counseled about double switch surgeries because late onset LV failures do happen. And for adults with TR with good ventricular function, a valve replacement along with PA banding. But with ventricular dysfunction, then probably they should be sent straight away for the cardiac transplant. CTGA VSDPS, Rastelli versus Fontan should be catered to the need of patient rather than what you feel should be done. Biventricular pacing should be preferred over single ventricle or dual chamber pacing. And we must remember, and this is what I want to tell everyone, that the risk of high-risk surgery is taken by the patient and not by the doctors. So sometimes it may be prudent just to go for a univentricular repair rather than offer a complex biventricular repair. Thank you.